Dr. Merchant, tell us about yourself. Where are you from? Where did you study medicine, sir?
Hi, good morning. Thanks for having me here with you. So I'm from Canton, Massachusetts, and so I grew up in very close to Weymouth, where I practice now. And I went to medical school at Georgetown in Washington, D.C., and then I continued my training at Georgetown in D.C. for internal medicine. And after internal medicine, I moved to Worcester, where I did cardiology training at UMass Memorial in Worcester.
What influenced you to become a cardiologist?
A lot of the similar things for other people in cardiology. I think initially when you're training in medical school, physiology is one of the core competencies and core educational components of the medical education. So cardiovascular physiology for me, was always the most interesting. And then as I went into medical training, initially all cardiologists go through internal medicine. When I was in internal medicine training, I just noticed that for cardiology, you were seeing patients at all ages, all genders. You're really seeing patients across the spectrum of disease. And the other thing about cardiology is there did really seem to be, there's so much evidence behind the medications, behind the treatments in cardiology. And there are a lot of fixable problems in cardiology. So when I say problems, there's a lot of fixable medical conditions. And that was one of the things I really enjoyed about cardiology was you could be very optimistic with patients that they had a medical condition that you could really work on, and you could make the patient feel better. And that's one of the most important things in medicine is helping a patient feel better. And that's something that's behind all treatments in cardiology.
When we talk about heart health, there are many of us who seem to think that when we have an issue with our heart, it involves major, serious, invasive surgery, which is probably not the case. You mentioned that there are fixable solutions that may not necessarily involve surgical procedure. Is that right?
Oh, absolutely. When we think about cardiovascular health, a lot of cardiovascular health starts with lifestyle and behaviors. And there's so much empowerment for patients. And there's so much information now, especially with the internet, with digital medicine, with wearable technology. There's so much that patients can do long before they even come into the clinic. And so a lot of cardiovascular health occurs long before there would ever be any type of invasive procedure or surgery. There's also a lot of conditions inside cardiovascular health that will probably never involve any type of procedure. One of the most important things in cardiovascular health is hypertension. Hypertension is almost always managed with lifestyle changes, exercise, diet, and that's one of the most rewarding things in cardiology is really just sitting in the clinic and working with patients over a period of time. And we see these patients for years, and there's a lot of enjoyment in working with patients and working with family members to help patients identify healthy lifestyle choices and behaviors that can contribute to their health.
I like your reference to empowering the patient. Patient empowerment, I guess, is a better way to put it. Dr. Merchant, let's talk a little bit more about patient empowerment and how can that patient be more of an active participant with their doctor when they may suspect that they've got some cardiology issues. So where does that start?
In all of medicine, medicine's a team sport. So there's the patients on the team, the doctors on the team, the families on the team, and everyone is bringing something to the table. Now, from a standpoint of empowerment, one of the things I've noticed that with each year and with advancements in technology, patients seem to be more knowledgeable, more intelligent, and more aware of medical advances, medical devices and medical information. So I think patients are already fairly empowered, especially with the use of the internet. And I don't think they should have any fear about asking any question of their doctor, whether it's their primary care physician or whether it's a cardiologist. One of the very common things patients will ask about is family history of cardiovascular disease, and there are certainly some cardiovascular diseases such as hypertrophic cardiomyopathy that we know there is a direct dominant inheritance pattern where it's passed from one generation to the next generation. But then there's also a family history of cardiovascular disease. And when I say family history, I mean that there's more of an association. So when there's a first degree relative, a mother, a father, a sibling, those first degree relatives are at greater risk for cardiovascular disease. And those are the questions that we really enjoy dealing with in clinic. And that's when I want patients to ask as many questions as they can. And Joe, I think earlier you were sort of asking about blood pressure, and that's in that conversation is managing blood pressure. Also in that conversation is lipid management and cholesterol management. We know that controlling someone's cholesterol, if we can lower someone's LDL, whether it's by lifestyle or by medications, we know that we can reduce someone's risk of having a heart attack or a stroke. And when we can share that information with patients, when patients feel comfortable asking about their family history, and we can share that information about lowering cholesterol and how we do it, I think that gives patients empowerment to feel better about their risk and about their future.
And you mentioned hypertension as one example, because among certain groups, whether it's based on ethnic groups and or gender, there's a sense that hypertension, well, that's just my lot in life. I have to live with it. But is that true?
No. Certainly there are some people that are more predisposed to have hypertension, but hypertension is so treatable, and the information and the research on hypertension goes back decades, showing just something. I don't want to characterize it as basic, because dietary sodium is something that every single person should be aware of, especially patients that are predisposed to hypertension. And that's something that we work with patients in the clinic, and you brought up empowerment. We help patients learn to identify reading nutrition labels. They're learning healthy diets. So I would say that patients don't have to accept this fate that they're bound to have hypertension and it can't be controlled. There are a lot of lifestyle changes that can work to help control hypertension. And then we have excellent medications. Certainly people, sometimes are a little bit wary to take medications, but we work with them. And that's, again, we see patients over a long period of time. We always refer to hypertension as sort of a silent killer. It's not something that ever hurts anyone overnight. It's something that hurts people over decades. And that's why we're working with patients over a very long period of time on these lifestyle changes, but also on medications. And we have a lot of research on the diets, and we have a lot of research on the medications. So we can definitely control hypertension.
Dr. Merchant, can you tell us about some of the new techniques that are being used for examining cardiac health?
Absolutely. So I think in terms of cardiac health, for this question, I'd like to answer as it relates to coronary artery disease and atherosclerotic cardiovascular disease. What that is, it's a cholesterol-mediated process. Now, traditionally, we still follow lipid panels. We follow someone's, their bad cholesterol, that's the LDL, and we follow the good cholesterol, which is phrased as the HDL. Sometimes a lipid panel alone is not able to capture someone's full risk. I think an example of this would be patients on the younger end that have a family history of a first-degree relative with coronary disease. So as an example, I'll commonly see a patient that's 45 years old and they have a brother or a sister that had a heart attack at the age of 51 or 52. And the patient will want to ask me their risk. Now, a lipid panel is a wonderful first test, but in some of these patients, I also get something called a coronary artery calcium score. What it is, it's a non-invasive test. It's a CAT scan. There are no needles, there's no contrast, and it's a very quick, I almost describe it to patients as a quick Polaroid of the heart, and it looks for calcium. And we know that calcium is a marker of subclinical disease. What I mean by subclinical is, these patients have a risk factor. Their risk factor is a family history, but they've never had a clinical event. So, back to the example of the patient, the 45-year-old with a sibling that has had a heart attack. The 45-year-old patient has never had a clinical event, and we're trying to give them a better prognosis or more risk stratification. And that's an example of a new technology, which would be the coronary artery calcium score, which is a tremendous predictor of risk. If someone has no calcium, then they are exceedingly low risk to have a heart attack. And on the other hand, if someone has a very high burden of calcium at the coronary arteries, then we have to be more aggressive about managing their risk factors.
Dr. Brendan Merchant, thank you so much for visiting with us. We look forward to another visit in the future and continuing our conversation about cardiac health.
Thank you, Joe. Thanks for having me.